Thank you very much. And let's move on to the first section. And Simon, the microphone is yours. Thank you very much.
Thank you. So we'll begin the first session of the webinar on acute painful vision loss. There will be 3 presentations followed by time for Q&A or discussion as introduced by Murat earlier. The presentations will be given by, first of all, Angela Panico from Italy, discussing microbial keratitis, followed by Zeynep Aktas from Turkey, discussing angle closure glaucoma, the acute management, and finally by Florence Hoogewoud from Switzerland, discussing acute anterior uveitis differentials and assessment. So we'll kick off.
The microbial keratitis are infections of the cornea associated with signs of inflammation caused by bacteria, fungi, viruses, parasites, and protozoa. The early symptoms are discomfort, dry and irritated eyes, foreign body sensation, watering, and eyelid swelling. The early symptoms increase with the time and then occur severe pain, photophobia, discharge, and blurred vision. The signs are infiltrates in the corneal stroma with or without epithelial defect, signs of inflammation from redness to hypopion. The first step of diagnostic workup is the clinical history to investigate the risk factor, in particular the contact lens wearing, the exposure to contaminated water, traumas, and comorbidities. The examination of the eye starts from check the visual acuity for medical and for potentially legal reasons, then check the eyelid to find out abnormalities predisposing to keratitis and fornix under the upper eyelid, looking for conjunctival foreign bodies. Then the examination of the conjunctiva, that could be swelling, could have the discharge, and the injection of the conjunctiva could be diffuse or sectorial. The aspect of the cornea, in particular the size and the shape of the epithelial defect and of the infiltrate, that could be single and central or peripheral and sometimes multiple. The examination of the cornea is important to find out the signs of a pre-existing condition, such as foreign bodies, scars, especially in case of a recurrent herpetic keratitis, where we can find a corneal anesthesia. Then the inspection of the anterior chamber. In the anterior chamber, we could have an inflammatory reaction with hypopion. The hypopion could be sterile, sign of inflammatory reaction, or infected, sign of a spreading traveler infection. Now let's go see key features to direct the clinical differential diagnosis. In case of a viral keratitis, the pain is mild, the vision is slightly blurred, the discharge is watery, and the infiltrates of the cornea has the characteristic features after fluorescein staining, arborescent. In case of bacterial or fungal, the pain is mild to severe, the vision is very blurred, the discharge is purulent, and the infiltrate of the cornea are white, whitish, or yellowish, sometimes single, sometimes multiple. In case of acanthamoebal, the pain is mild to moderate and disproportionate to clinical sign. The vision is blurred, the infiltrate are non-responsive to usual antibiotics drops, and the typically ring shape is only in the conclamated stage. It's impossible to be certain whether the cause of keratitis is bacterial, fungal, or acanthamoebal. The corneal scraping is necessary to do the microbial examination and to have the exact microbial diagnosis and to check the sensitivity of the antimicrobial drugs. So the keratitis are emergencies because of the risk of potential loss of the vision of the eye or of the eye. And as earlier is the diagnosis and more targeted the therapy, as lower is the risk of permanent complication. And a crucial role as a prevention to inform the patient about the risk, especially those of the incorrect wearing of the contact lens, reduce the risk of onset of a severe keratitis. I would to thank you for your attention and I wish you a good evening.
Dear colleagues, this is Zeynep Aktas from Turkey. And I'm going to present 43-year-old female patient presented with pain and redness and decreased vision in the left eye. She had a history of recurrent intermittent eye and forehead pain together with retinitis pigmentosa. As you see here in your left eye, she has severe corneal edema, shallow AC, and pupil was mid-dilated and intraocular pressure was 52 millimeters mercury, and in the right eye, AC was shallow too. With this clinical picture, patient was considered as primary angle closure glaucoma. IV Vantol was given, and we put her on Pilo along with Actos suppressants and steroids to make the eye ready for LPI. And then LPI was done. And as you see here in these UVM images, there is a combined mechanism here in this case, pupillary block together with anteriorly located ciliary body. And you can also see here the absence of ciliary sulcus. And in the second day, you see here the LPI was very small and intraocular pressure was 20/20, and there are some descending membrane folds. And here you see the patient's follow-up on 5th day, IOP was 19 millimeters mercury, and on 10th day, IOP tended to rise again. It was 23 millimeters mercury. And after the LPI, as you see here in these UVM images, the letter iris configuration is more clear. Here, AC is still shallow, and other than that, axial length was 18 millimeters. And on gonioscopy, there was a double hum appearance, which is typical of plateau iris bilaterally. You can also see here anterior chamber is very shallow, 1.2 millimeters. On the other hand, on OCT, there was no retinal nerve fiber layer defect. Fundoscopy revealed typical retinitis pigmentosa appearance characterized by attenuated vessels, bony spicles, and waxy pallor. Since the patient has a recurrent angle closure attacks, short axial length, together with uncontrolled intraocular pressure, cataract extraction was done here in this case. And we are trying to maintain anterior chamber in this high-risk case and taking the lens out. And after the lens implantation, at the end of the surgery, we did iridazole highlighter vitrectomy, since this eye has a high risk for development of malignant glaucoma. Here in this slide, you see the preoperative and postoperative change in anterior chamber depth. And here, postoperatively, intraocular pressure was 13 millimeter mercury. And right after the cataract surgery, as you can see here, anterior chamber depth was increased to 2.74 millimeters. And this is the postoperative appearance of the patient. And on the left-hand side, this is right after the operation. You can see the descending membrane folds. And on the right-hand side, you can see the postoperative first-year follow-up of the patient. IOP was 16 millimeter mercury unmedicated, and visual acuity was 20/20. So in these cases with retinitis pigmentosa, there might be combined mechanisms of angle closure, like zonular laxity, plateau iris, and pupillary block. And imaging like UVM in these cases is of paramount importance. And generally, pupillary block is the most common mechanism. And medical treatment and LPI, generally the first approach. On the other hand, lensectomy can be done at first place, according to Eagle study. Short axial length is one of the most important risk factors for the development of postoperative malignant glaucoma. To prevent this complication, iridozonal highlighted vitrectomy might be done. And timely intervention can prevent further damage in these high-risk cases. Thanks for your attention.
Hello, everyone. Welcome to this webinar. So I'm going to present a case of anterior uveitis. It's a 59-year-old male who came with the ER with the straightforward history of red painful eyes in 3 days. He had no relevant medical history. So the status was like that. There was granulomatous precipitates and acute uveitis with inflammation, and the fundus was normal. So it was an acute anterior granulomatous uveitis. So the resident made the first investigations, which were all normal, and he started with steroid drops with a complete resolution of the symptoms. But 3 days after stopping the drops, he came back with a recurrence of the inflammation. That time, there was a very clear iris atrophy, which did us make the diagnosis of herpetic uveitis. Looking backwards, this iris atrophy could have been detected easily when looking a bit more precisely to the iris in the first picture, which was already deformed. The aqueous tap confirmed the diagnosis and revealed the presence of VZV uveitis. So why is it so important to detect the early signs of an iris atrophy? Because iris atrophy is very frequent in VZV-related uveitis, 25% in the acute stage. It can be graded in 3 types of severity. It can be either only basal or has a sphincter involvement, or it can even be diffuse in 6% of the cases. In this series of proven viral uveitis without corneal involvement, the iris atrophy was even more frequent, also 3/4 of the uveitis. So it can be obvious, like in the second picture of our patient, or it can be very subtle, like in this patient. But you really have to look specifically for iris involvement when you're confronted to anterior uveitis. And it's so important because if you have an iris atrophy, it almost confirms the etiology of the uveitis. In this series, 24 patients had it, and the taps were positive in 23% of the cases for HSV and VZV. So iris atrophy is very specific for herpes infection. What are the other clinical signs that can be helpful? Of course, the corneal involvement. But when I speak of the corneal involvement, I speak of the scars or of the reduced corneal sensation, but not about the corneal edema, because it's not specific to herpes. It's in the context of an ocular hypertension. Every high pressure can make a corneal edema. You can also look at the type of precipitates. All herpetic uveitis have precipitates. Most of them are mutton fats, so granulomatous. And they usually have often a pigmented appearance, which can distinguish them from the typical PKs found in Posner-Schlossmann or Fuchs uveitis. What can distinguish HSV from VZV? Of course, the skin rash. Ocular involvement is usually within 30 days after the skin rash, but the skin rash is not always present like in our patient. In fact, in a series of 90 cases of zoster ophthalmicus, 5 patients developed uveitis 6 months to 16 years after the skin involvement. So patient has a lot of time to forget it. Also, if you compare the demographics, HSV is much more frequent in younger patients and VZV in older patients. So that's also a clue. And keep in mind that vis-a-vis uveitis is always unilateral, but HSV can be bilateral in 18% of the eyes, which is not that few. So in conclusion, the diagnosis of herpetic-related uveitis is very probable if you have a corneal involvement, an iris atrophy, or if it's following zoster ophthalmicus. If you don't have those specific signs, the diagnosis of herpes is uncertain and it can only be confirmed by microscope. So I thank you for your attention. I hope you learned something and I wish you a good webinar.
So thank you, Angela, Zeynep, and Florence for your great presentation. So we now have a chance to discuss the talks we have just heard, and we have had a number of questions from the audience. So the first question is for Angela. You mentioned about corneal scraping. How large should the bacterial infiltrate be before you perform corneal scraping? That's the first question.
It depends. The cases are very different. Their shape, about 3 millimeters, is for me a shape, a large of the corneal infiltrate that suggests to do the corneal scraping. In general, in case of size less than 3 millimeters, I prefer not to do the corneal scraping, but it's different cases by cases.
Thank you.
Maybe I can ask this question to maybe Florence regarding the emergency of uveitis. Basically, uveitis and the acute glaucoma cases intertwine with each other frequently, especially when the patient arrives with high intraocular pressure. Do you have a tool to differentiate those cases, like differentiate an acute uveitis attack from like an angle closure glaucoma? What kind of tools do you use in general?
Well, first, things to look at the angle, obviously, which is
of course.
Seems logical, but some residents assume that if the pressure is 50, the angle is automatically closed. But that's the first thing. And look precisely for small precipitates, which are not normal, not uveitic glaucoma. Yeah.
Okay. Thank you.
So we have a question for Dr. Zeynep. So the question is lancectomy suggested to be better done for both eyes to prevent recurrence in the other eye? And is it of high risk to have a recurrence on the other eye when you have one eye that had angle closure?
Okay, so great question. Yes, I totally agree. There's a high risk of the recurrence in the other eye, since this is just a kind of primary angle closure glaucoma. So the other eye is also, fellow eye has a tendency to develop the same clinical situation. So the lancectomy is one of the most important part of the treatment plan, that's for sure. And of course, we recommended cataract surgery for the fellow eye in this patient, but we should keep in mind that cataract surgery should be done in experienced hand in patients with, especially with short axial length and high risk eyes, because these clinical situations can get complicated easily. So I think that's the most important part. And yes, I agree.
Thank you. I think we have maybe just one more question time. So the question here is back to Florence. What do you think of peribulbar steroids in herpetic uveitis with oral antivirals?
Yeah, I use that frequently. Yeah, especially if there is corneal involvement and you're not, you don't want to put too many drops of steroids. So I use that really. And for the other question about the pupil distortion, it's the beginning of the edge distorts the pupil. So yes, it's frequent in herpetic uveitis.
Okay. Well, thank you very much.